Okay, so we got a few more questions left. The other one that I had for you was, how do you organize your notes and the information that you gather from the patients?
When I pre-chart, I try to keep everything organized. Color coding, if you can get one of those pens that have different colors, will be super helpful too. Always, you need to know the name and the age of the patient, and then I kind of write the notes in the order I would present the patient in. So I'll write the name, the age, the past medical history of the patient, why they're in the hospital, why they were admitted, and then go into the HPI. So that's like the different mnemonics that everybody learns, and then what interventions were done in the emergency room, if any. You know, were they given any medications? What testing did they have done there? Was it significant? So you can mention that, and I usually I'll color code labs and imaging in red, so I know that's like the diagnostic and that kind of stuff. And then I'll leave a little space, so I'll fill in basically review systems when I ask the patients, and kind of an update, overnight update, or any new symptoms that they might be having. You know, if they're in pain, is it controlled on medication? Are they, you can tell by looking at the medication list what medications they're getting, and kind of just any changes. A lot of attendings know what's going on with the patient already, especially if you've been following them or if they were there the previous day to admit them. So you don't need to go too in depth, so it really depends. But I kind of just try to follow that
the subjective
format.
Information.
Right. I follow that format when I'm chart reviewing, just to make it organized for me, because sometimes they'll ask you questions about what happened 2 days ago, and I don't remember, but if you write it down, you can remember. And then just keep those notes, because if you're following the patient the next day, you already have that done, so you can just write, you know, any overnight stuff, or like what their most recent vitals were, any significant changes, and kind of just go from there.
So you have like one page for subjective, one space for objective, one space for assessment and plan.
Exactly. Yeah.
Okay, that's smart.
Sorry, I should have phrased it like that. That was just a much more concise way of putting it.
Yeah, you summarize the subjective information, which helps a lot. Like to just write it down the way that you're going to present this, so that you don't have to go all over.
Exactly. Otherwise, you're going to be there, kind of like how I'm giving you guys this discussion now. Like, I'm kind of all over the place. When you write everything down in the order you want to discuss, you don't need, your eyes are not shifting everywhere. It's very stepwise and decreases anxiety tenfold when you're on rounds.
Do you take a lot of paper for patients, or just?
No, I usually will grab some paper from the printer. I know I'm so bad, I shouldn't do that. But I'll like fold it up. I kind of make a little booklet, and then I'll leave like half a page per patient, and that's enough. And then you keep those pages, so the next day you can like add on if you need to.
And then, what are some important things about the hospital environment that we should know? Like maybe machines in the patient's room or something like that.
Honestly, I feel like I don't even know that stuff. Like when the machine beeps, it's very annoying to the patient. So there's a silence button. You can just hit the silence button while you're in the room with the patient, and then it'll tell you like if you know the IV is occluded, or if maybe the bag of whatever was running has just run out. So just let the nurse know, and they'll do all of that stuff. Trying to think what else is in the patient's room. But yeah, the nurses are great, and they handle all of that stuff. But always, check to see what's running in the IV when you go in, just to make sure. Usually, you're always going to get asked on internal medicine, was the patient on fluids this morning when you saw them? So always check, because sometimes it can be a little difficult to see in the medical record whether you can see when it was started. Sometimes it gets a little difficult to see if it was stopped or when it was stopped, so always check.
Okay. And then when it comes to like if they have a catheter in place or anything like that, if you see that it's full or something like that.
Yeah, so I was just thinking, I forgot to mention that. Yeah, if they have anything in place that's draining, find the source and always check to see the amount of whatever's drained. Like if they have a urinary catheter in, check to see how much output they've had, and then you can ask the nurse like when the last time they cleaned it out was, because inputs and outputs are a very big thing that a lot of times you're gonna have to keep track of.
It's important, and it can be part of the subjective information as well. If you see that it's dark, or
yeah, if you see it's dark or like cloudy, foamy, and then also the value, like you know, the milliliters or liters that they're putting out is important, especially when you have a patient on diuretics and you want to make sure that you're getting the fluid off appropriately and not over diuresing the patient. So that's when you'll really need those.
And if you wanted that from you know, to obtain the ins and out from the patient, it needs to be like order, so that the nurses do that, right? So it's not automatically they do it for every patient.
Right. So as a medical student, and again, this might differ depending on the hospital, you don't put in orders. So I really haven't noticed if it's like a separate order you have to put in. I think it might be, like I think you actually
as part of the assessment and plan.
But definitely, yeah, you would see that in the notes, like they would write like strict inputs and outputs, and then I guess you just hope that whoever is, you know, the nurse is seeing that and recording accurate values. And yeah,
got it. And then, do you do any procedures as a third-year medical student?
So most of the time, you're not doing procedures on your own. Especially, it gets a little tricky when you're with residents, because their learning, of course, it takes precedence, and we'll get more opportunities to do things. But I would say, as a third-year medical student, you're lucky if you get to draw blood and assist in things. I got to assist in a couple lumbar punctures, which was cool. Obviously, I'm not doing the actual lumbar puncture. I think it just has to do with liability and having a medical student do it. So,
epidurals?
Epidurals.
In OBGYN?
And that's an anesthesia thing. The OBGYN is not doing it. I mean, you can possibly do it when you're in anesthesia, but the problem with that, or I shouldn't say it's a problem, but you have the nurse anesthetists that do a lot of that. So I feel like a lot of the work or a lot of procedural stuff kind of gets passed around to other people, to the point where students are not always able to do it. But I think if you show an interest and or you know something's like a procedure's coming up and you want to partake in it, definitely ask. The worst thing that's going to happen is you're going to be told no, sorry, you can't. But at least you know you've tried, right?
Yeah.
So
I was thinking maybe like putting in IVs, or
I think you can. You would have to talk to whoever would be doing that originally. So that would mainly be the
emergency
medicine. Nursing staff if they're on the floor, and then if you're in the ED, so if you're in the ED, you actually get to do a lot.
In the ED,
you do a lot. Yeah, if the emergency physician is doing it, I feel like, I don't know. Again, it depends on who you work with and the hospital you're at. But if they're very inclined to teach, they might actually let you like do stuff. So yeah, it depends.
And then, have you experienced any cold, like code blue?
So I don't know if this is unfortunately or fortunately, have not experienced any codes firsthand. So just a pro tip, when you're rounding and you hear an alert come on in the hospital, stop what you're doing. Even if you're presenting, stop for a second so that the team can hear for any codes, because you want to make sure it's not one of your patients on the list coding and you have to go see them very rapidly. So never had a code.
If we were to have one, what do you think it's a role?
A role
in that situation?
So I haven't seen one firsthand. I'm sure it can get pretty hectic. So I would imagine med students probably just step aside, because you have so many, you have nurses, you have the residents, you have the attendings. I will say though, if you're even just observing and you feel like something is wrong, you have the duty to say something and stand up for the patient. I had one of my residents on internal medicine tell me that when there was a code blue called for one of his patients, and so he rushed there immediately, and nobody was really doing anything for the patient, and the patient was DNR, which you wouldn't resuscitate, you wouldn't intubate, but the patient's blood pressure was dropping, and I didn't know this until he was telling us the story, but standard of care includes giving the patients fluids and vasopressors, which the nurses were not doing. So,
if they're DNR, they needed to do something.
Exactly, yeah, because that's the standard. I guess DNR doesn't encompass that. So, he felt like they were doing a disservice to the patient, so he, started getting everything advocating for the patient. And I think one thing he was very proud about was
really good.
Yeah, if he wasn't there, the patient probably
suffer more,
passed away. So yeah.
Okay, and then do you have to communicate with the family as a third-year medical student?
It depends. So if you're on psychiatry or you're on a service and you need more information, let's say a patient is altered and they can't give you a full history, chances are you're going to be the one who calls the family or close friends to find out more about the patient and why they're there. In terms of plan, you can speak with the family. Always run everything by your residents and your attending and make sure it's okay to do that before you talk to them, and make sure you have a plan, because as a student you don't want to tell them one thing before discussing it with the team and then realize your plan was not the plan that they're going with, or they want to change a couple things, because then the family will be confused and they'll also be like, well, somebody told me something else. So
exactly. Yeah.
Be careful with that.
Good advice. And then the last question that I have for you is, do you have any advice? This is a concern for me because I get lost everywhere. So any advice on how to not get lost in the hospital?
Okay, so I actually got lost coming here. So I don't know if I'm the right person to talk about that.
I feel like there's no signals. There's nothing to get by in the hospital.
So eventually you do get used to everything. There will be a couple places where you don't go too often, and when you're asked to go there or you go there, you're like, this is new to me. Definitely in the beginning, when you're first there, it's confusing, especially when you're on a service like OBGYN, where you have the whole labor and delivery floor for OB, and then you have the regular floor for the GYN patients, and then you have to go down to the emergency room for consults, and then because of the pandemic, the emergency rooms could be packed and you have to go to the auditorium, which is
oh wow,
who knows where in the hospital. So you get used to it. You can always ask somebody.
Did they give you a tour?
I didn't get a tour. I don't know, maybe
there's someone that shows you around.
No, I didn't get that.
The first day
I'll take you though.
Okay.
I'll take you, yeah.
You see, this is great.
I'll show you around because I know what it's like.
Thank you so much, and thank you for being part of this video. I'm so excited, and I hope you guys found this helpful. If you have any additional questions for her or for me, please make sure to leave them down below. And yeah, thank you so much.
Thank you for having me.
Bye.
Good luck.
See you in the next one.